Good afternoon. I'd like to thank the Congress and Abraham for inviting me to speak on pre-implantation genetic screen for aneuploidy, also called PGT-A. I currently have a large practice in Houston in which we perform in vitro fertilization, and most of our patients now are utilizing the embryo biopsy for genetic screening. Good afternoon. In order to perform PGT-A, the patient undergoes the process of in vitro fertilization. Eggs are collected, they are fertilized with sperm, and the embryo is grown to day 5, called a blastocyst stage. During the day 5, or possibly if they don't grow to day 5, we wait on day 6 until they develop a blastocyst, and then we use a small little opening in the trophectoderm using a laser. A small biopsy is then done on the trophectoderm using approximately 3 to 5 cells, and then those cells are placed on a slide, and then we send them off to a special labs for analysis.
When we first implemented trophectoderm biopsy, creating a slit in the zona pellucida, collapsing blastocyst, and harvesting cells were all combined into a single procedure. But we were never completely happy with this approach because blastocysts collapse at a different and unpredictable rate. Some blastocysts require aggressive manipulations before a sufficient space between zona pellucida and trophectoderm is available to proceed with the biopsy safely. This not only increases the time for the biopsy, but also may reduce embryo viability. Another problem is that the opening in the zona pellucida is in the same plane, with the cells already damaged by laser. As a result, the trophectoderm often ruptures prematurely, making biopsy messy. Hatching embryos on day 3 solved many of these issues. However, we observed that manipulations with day 3 embryos may slow down their development. Also, sometimes the embryo hatches by the inner cell mass first, or the hatching part ruptures zona pellucida more than would be desired, so that the embryo can be inadvertently pulled from the zona pellucida completely. Our new technique, which we call minimal impact biopsy, helps to mitigate many of the current shortcomings. Minimal impact biopsy is performed entirely on day 5 without hatching on day 3. First, all blastocysts selected for a biopsy are given a single shot of a laser in a herpes buffered medium. Even though you may not see any immediate reaction or changes, the single laser shot will suffice to trigger the collapse. Immediately after the laser treatment, embryos are returned into the culture. 15-20 minutes later, the blastocysts are once again transferred into the droplets of the herpes buffered medium. Now, with an ample space between zona pellucida and the embryo, you can make the slit in the location you like and the size you need safely and quickly. Then proceed with the biopsy in your custom fashion. Thank you very much for listening. Have a great embryo biopsy. When we first implemented trophectoderm biopsy,
I would like When we place the few cells on a slide and send it to a company, current methodology is used called whole genome. We amplify the whole gene by a process called next generation sequencing. When we use next generation sequencing, it allows us to amplify the entire genome, and then that allows us to have almost no false positive or no false negative results. And what we do is compare the DNA on the embryo to a normal DNA. When we place the few cells on a slide and send it to a company, current methodology is used called whole genome, we amplify the whole gene by a process called next-generation sequencing. So when trying to figure out if the process of preimplantation genetic testing is useful or not, looking at the data in the past, there were about 5 randomized controlled trials which showed for the most part that it does benefit pregnancy. It showed that they have a lower total cost to the patient due to the fact that we don't do as many embryo transfers and we can pick up the best embryos. They also demonstrated that you have a less risk of having a pregnancy with multiples and you're able to transfer only one embryo. So by us transferring one embryo, we minimize the risk of preterm labor, premature rupture of membrane, and other complications that are associated with twins or more gestation. Next, I'd like to talk about what we call the STAR trial. The STAR trial is one of the biggest trials there is to identify the benefits of preimplantation genetic testing. The trial included 650 patients. It was a multi-center randomized trial. And in that trial, there are several results that we should consider. They actually showed that the miscarriage rate were not improved by doing preimplantation genetic screen. They showed that pregnancy rate were mostly improved in only the patient over 35. And the problem with the trial was that it's very difficult to compare multiple centers because you don't have the same randomization of patients in different centers based on age and equally distributed. In other words, if one center had more young people than the other, and randomization becomes much more difficult. At the same time, they did not use any mosaic embryos for the transfer, so that kind of perhaps have a different outcome. When we talk about genetic testing for our patients, it is very important to remember that if you look at patient ages, i.e. less than 35, or 35 to 37, or 38 to 40, the miscarriage rate or the incidence of possibly aneuploidy really is approximately 40 to 50%. Now, if you look at the patients over 40, the aneuploidy rate is like 57%. So we're trying to figure out the fact that in most of our patients, the incidence of abnormal embryos is pretty high based on their age. So when considering performing the PGT-A for aneuploidy, it's important for us to remember that aneuploidy consists of approximately 50 to 70% reason that women can have a miscarriage or failed embryo transfer. So it's a considerable factor of pregnancy or non-pregnancy. We feel that by doing the embryo biopsy, you can possibly increase the implantation rate up to 60 to 80%, even in our older women over 40. The fact that we can eliminate chromosomal abnormality and then transfer a normal embryo, hopefully we can improve implantation and the development of the embryo to a successful pregnancy. It is effective in the fact that now we can transfer one normal embryo and we don't have to transfer several embryos at the same time. So among the advantages of doing the embryo biopsy is that you decrease the number of transfers that you're doing, so you don't have to transfer abnormal embryos and end up with non-pregnancies or a miscarriage. By doing less embryo transfers and less IVFs, you then decrease the total cost to the patient. It also will particularly benefit a patients who have recurrent more than one miscarriage, and we're able to decrease the risk of a miscarriage by transferring one normal embryo. It is also important to remember that PGT-A can identify the mutation of the BRCA1 gene. This gene mutation can actually detect about 80% risk of breast cancer and about 40% risk of ovarian cancer. We definitely would like to eliminate these gene mutations from the woman passing it to our daughter or granddaughter. By doing PGT-A, we can basically eliminate it from the family passage in the next generation. Also, it's important to remember that you can use PGT-A for any family who has a history of a single gene mutation, and you can actually have genetic counseling, see if the couples want to do it. Then if they do the IVF, perform the embryo biopsy and eliminate it from their offsprings. Third thing, we think that PGT-A is particularly important because it eliminates the trauma of terminating the pregnancy once there's abnormal gestation is encountered. So the patient doesn't have to go through the pregnancy and then termination before they're successful. This slide kind of helps us see the effect of PGS pregnancy rate in a different age population. And what they did, they compared doing the biopsy in patients that are 25 to 34, 34 to 35 to 40, and all age groups. As you see from this slide, the particularly important value was in the group of 35 to 34-year-old pregnancy rate were improved. The other group of less than 35 and over 40 pregnancy rates were not improved. The process of doing the embryo biopsy for PGT-A, we can eliminate the risk of recurrent miscarriages and spontaneous abortion. We definitely can eliminate the risk of Down syndrome in older women like a trisomy 21. And it's very effective in eliminating miscarriages with trisomy 13 and trisomy 18. Also, it is important to remember a triploidy, which happens with male factor. 1 to 3% of all IVF embryos can end up in triploidy, and 15% of all first trimester. They're usually due to male factors, and those can be easily eliminated by doing the embryo biopsy. When you do less embryo transfers, you also, again, reduce the cost to the patient. By doing the embryo biopsy, it is important to consider that you're actually decreasing the lifetime cost of patients who have chronic medical condition. We think that by doing the embryo biopsy and selecting the best embryo, you decrease the time to when you start and when the patients are pregnant, i.e. you'd have to do less cycles and less embryo transfers. You also will eventually improve the pregnancy and live birth rate in women that are older than 37. We can now focus our attention on what are the actual disadvantages in doing the pre-implantation genetic screen. It is important to think about it. It is an invasive procedure, and about 1 to 5% of our patients, there is a possibility that you send the biopsy and it's called they couldn't read it. In other words, there are actually no results. Why? Because there's only 5 to 10 cells are tested, and sometimes they can't pick up the abnormality. What that means is that you have to go back and do another biopsy of the embryo. So when you do a second biopsy on the embryo, it can actually lower the survival of that embryo and can damage the embryo and cause a lower clinical pregnancy rate. It also gives you the problem where you don't have any normal embryos. You have to go back to the patient and say, well, we're very sorry, we don't really have any normal embryos. We have to start everything over and do another IVF retrieval and embryo transfer. It's also important to consider that there's a lot of variation in different lab, the techniques between the embryologists, the ones that are doing the biopsy, and different centers can cause different variation in the outcome. The other things that we should consider about the disadvantages of PGT-A is that sometimes they have a genetic trait but actually live a perfectly healthy life for several years and never actually manifest the disease. Also, there should be either a mild or very minimal or no expression of the illness, and you tell the patient, well, that could be in your family. And then when the family knows that they have a mutation, they have a negative effect on their value and life in the future, they know, oh, I am carrying this genetic mutation. And also, it's very important to consider that you may give the wrong diagnosis just due to technical reasons. So the hope that doing the genetic testing on the embryos can actually improve the pregnancy and lower the miscarriage rate didn't really pan out. And you can see from that slide when they looked at different age groups from 25 to 34 or 38 to 40 or all age groups, doing the embryo biopsy did not really reduce the miscarriage rate. Next, I wanted to talk about something that we often struggle with, and that's called mosaic embryos. Mosaic embryos are made from about 5 up to 30% of blastocysts considered mosaic. And when we talk about mosaic, is sometimes we have an embryo with two or more genotype in the same embryo. And that when you do the biopsy, you don't really know where are you taking the cells from. The mosaic embryos occur from a meiotic uh, division or non-disjunction or anaphase lag or chromosome breaks. So any meiotic abnormality in the division can cause mosaic embryos to form. This slide kind of gives us a nice view of when you compare an euploid embryo, which is normal, compared to totally abnormal embryo, and a mosaic embryo, which is almost in between. So if you could see this mosaic embryo, it has both normal and abnormal amount of cells. So it's not perfectly normal and it's not totally abnormal. The likelihood of producing a pregnancy is not as high as a normal embryo. It's quite low. And the problem that we have is that we can usually transfer it if we don't really have anything else to transfer. In other words, if this is the only embryo we have, then we'll end up transferring it. The problem that we have with mosaic embryos is that the actual trophectoderm doesn't represent the inner cell mass where the embryo's development develops from. The cells that we obtain by biopsy may actually die during the early development of the embryo. And for the most part, the majority of mosaic embryos don't implant and they are more than 2 times likely to result in a miscarriage than a live birth. The problem that we have with mosaic embryo also is the fact that a very small amount of DNA is contaminated by the maternal part of the DNA cumulus of that embryo. And a study that was done by Monet et al. Found that mosaic embryos have with a lot of abnormalities, like even 40 to 80% of abnormal cells, really had very low implantation rate. Also, it's important to consider that when you do place that embryo, mosaic embryos can have a very high miscarriage rate, almost twice as much, like 25% instead of 10%. So not only do you not have a chance of a good pregnancy, you also have a high miscarriage rate, which none of us want. It is important to know that only about 4 in 100 mosaic embryos can actually reach a full-term pregnancy, and it's quite a low number. So when you transfer mosaic embryos, you really have to sit down with the patient. They have to have good genetic counseling prior to the transfer. It would really be nice to do prenatal diagnostic testing, like NIPT, and possibly do amniocentesis to kind of make sure that the pregnancy is really going to have a good outcome. One of the centers, like Coupa Genomics, they have a way that they report mosaics. They have two ways of reporting it. They have a low mosaic level, which they states that about 20 to 40% of the cells of the embryo are normal, which obviously will have a better outcome than if you have a high level mosaic, which 40 to 80% of the cells are aneuploid. So you kind of it gives you just another level of discrimination of, okay, do I put the I have a low level mosaicism, which of course is much better than a high level mosaicism, which can really result in a poor outcome. One of the ways that we deal with mosaic embryos is that if you can actually sequence about 5 to 8 million reads for each embryo, then it allows you to kind of look at the inheritance part, which is from the mom and which part is from the dad. You can increase your uh, sensitivity. Also, if you use something called SNP, which stands for single nucleotide polymorphism, and what it does, it kind of helps us improve the accuracy 10 times more by letting us know which copy is from the mom and which one is from the dad. Next, I want to talk about something that's is out there, but it's not used very common. It's called PGTP. So PGTP stands for Pre-Implantation Genetic Testing for Polygenic Disorder. And this company called Genomic Predictions, what they do is they use that same biopsy to predict the risk of other polygenic diseases. You know, they're pretty accurate. They claim to have about a 99.7% accuracy. What they do is they use artificial intelligence by taking millions of genes and they calculate the actual risk of diabetes and schizophrenia, and each embryo get a risk ratio. The problem with that company is that they can only use embryos from Caucasian or Asian ancestry, and the predictive power of other ethnic group is substantially reduced. When we are doing the pre-implantation genetic testing for polyploidy, the nice thing to remember is that just having the diagnosis of infertility will usually involve a higher risk of simple gynecological cancers. Also, other cancers like thyroid and melanomas are more increased in patients who are given the diagnosis of endometriosis. It is important to remember that this test also can give you the risk ratio of type 1, type 2 diabetes. It'll give you the risk of breast cancer, testicular cancer, prostate cancer, malignant melanomas, heart attack, coronary artery disease, hypertension, and schizophrenia. The nice thing is that if you know that there is a male factor, you keep in mind that just having a male factor, there's an increased risk of colon and endometrial cancer. So if you have a test that can give you a little bit more information than just the genetic makeup, it can give you the probability of having cancers in the future. I think patients are more likely to request it and use it for their future. I currently am not doing this test, but I think that the more I know about this company and these predictions that they're available, I think in the future that we'll tend to do more and more diagnosis. By doing the pre-implantation tested for polygenic disease, you can actually decrease the risk of adverse outcome by about 50%. It costs about $1,000 upfront, and each embryo tested is about $400. But it's important to remember that before you do the test, it's better that the patient is counseled and they know what the likelihood of positive results and what to do if the outcome is positive. In this slide, I got an example of what the result looked like, and I know it's hard for you to see from the slide, but this embryo is euploid female, but it also kind of gives you the probability of type 1, type 2 diabetes, risk of breast cancer. It also gives you other risk of malignant melanoma, heart attacks, coronary artery disease, and schizophrenia. To kind of summarize the advantages of doing pre-implantation genetic testing is that it allows you to transfer only one embryo at a time. You decrease the risk of multiple pregnancy like twins and other multiple gestation. By reducing the multiple gestation, you decrease the risk of preterm labor, premature rupture membrane. You can also identify mutation of BRCA1 gene, and you can eliminate about 80% risk of breast cancer and then eliminate 40% of ovarian cancer. And then you can eliminate that same woman from passing her to her daughter or granddaughter. Also, it is very important to remember that when you have an abnormal conception and you have to do a D&C, that definitely is a trauma to the patient. So by doing the genetic testing on the embryo prior to transfer, you avoid that trauma to the patient. Also keep in mind that if there is a family history of a single gene mutation, you can sit down with the patient, you can provide our genetic counseling, then do the IVF, do the embryo biopsy, and then you can better tell them, okay, we found at least one normal embryo, we can now proceed by doing the transfer, and then we don't have to worry about passing it to your offspring. The other thing to remember that when we're doing pre-implantation genetic testing, we kind of decrease the time that the patient will get pregnant. So if they're older and they're doing IVF, they get abnormal embryos, you don't have to do multiple cycles of IVF before they can get pregnant. You could do IVF, do pre-implantation genetic testing, find the normal embryo that you want, and then do the transfer. So the patient doesn't have to go multiple cycles, doesn't have to have, you hopefully eliminate the miscarriages with abnormal embryo, and you can transfer one normal embryo to the patient and result in a better outcome. It is probably most likely to be beneficial to a woman who is 37 years or older because you can eliminate the risk of Down syndrome, you can eliminate her higher risk of a miscarriage and transfer one normal embryo. Also, by doing the genetic testing, we really hope that we can eliminate the cost of the lifetime risk of a chronic medical condition, and hopefully the patient is baby is normal and have a good life. I want to kind of address briefly non-invasive pre-implantation genetic testing. What we do with non-invasive testing, you have to keep in mind that each embryo has to be kept separately in a dish. So in other words, you can't put 2 or 3 embryos in the same dish. Each embryo has to be in its own dish. And what they do is they basically take the culture media, collect the culture media, and do diagnosis on the culture media. And at the same time, they take a biopsy of the trophectoderm and then compare the culture media to the pre-implantation genetic testing results. This test, of course, is still in it's not ready for prime time, but it kind of gives us an idea of, okay, if we do the biopsy, how accurate can we be of just using the media around the embryo to do the genetic testing? As you know, the embryo sloughs cells all the time, and then perhaps the idea if you could just test the media, you don't have to do the biopsy on the embryo, you're not doing as invasive procedure, you won't damage the embryo as much and hopefully have a better outcome. But I think this process is not ready for prime time. It still has to undergo a lot of testing and prove that it's effective. The problem that we encounter with non-invasive testing is that when you do the fluid from the embryo, only a small amount of DNA can actually be contaminated from the maternal side, and that's not helpful when you have contamination. You also have a higher DNA of higher chance of having a failure to really get a diagnosis because you can't amplify so much of the DNA, and also because maybe the embryo wasn't enough time in culture. And at the same time, there's about a 40% what we call discrepancy between doing the biopsy itself to the actually looking at the fluid. So 40% discrepancy, I feel is still pretty high, and so that's why I don't think it's gonna probably pan out to be something that is used quite often in our field. Finally, I wanted to address something that is really becoming a hot subject in our field, and that artificial intelligence. What artificial intelligence allows us is to basically detect whether the embryo is normal using machine learning prior to doing an embryo transfer. So basically what you do is you can use the artificial intelligence to allow you to say, okay, is this embryo normal compared to all the others using the computer? And if that embryo is more likely to normal, perhaps you don't need to do the genetic screen. Or at the same time, you could do the genetic screen on the embryo and then use artificial intelligence to tell you, okay, this embryo is normal and that embryo is normal. But if you use artificial intelligence, can you actually say, okay, this embryo is more likely to result in conception compared to this other embryo? So maybe perhaps that will be the embryo that you choose. And so that will maybe perhaps tell you which embryo to transfer if you have more than one normal embryo and you want to increase the chance that this conception will lead to a good outcome. AI could probably help you. And also, I think that when you use AI, hopefully you can transfer that one normal embryo, eliminate the chance that you do multiple cycles, multiple embryo transfer, and hopefully the patients can get pregnant quickly and without having to undergo several procedures. Finally, I wanted to thank everybody for giving me the opportunity to present today. And I wish I was there and not doing a Zoom. And if you have any questions about PGT-A or even if you have any more questions about the artificial intelligence projects that were involved, you can email me at dralon, drallon, at dralon.com, and I will certainly be glad to talk to you further and give you more information. Thank you and have a great day. Bye-bye.